I'm Dr. Sunil Kumar TR. I'm a assistant professor in cardiovascular and thoracic surgery in UNMICRC Institute of Cardiology and Research, Ahmedabad. Today I'm briefly going to talk about surface anatomy of heart in relation to cardiac surgery. So, cardiac surgery, it's a broad topic. So here I'm going to discuss about the surface anatomy of heart in relation to majorly adult cardiac surgery, because pediatric cardiac surgery is a vast topic where the anatomy changes with each cases, with each pathology. So I'm gonna stick to the basic normal cardiac anatomy. So I'm going to talk about surface anatomy of the heart and anatomical location, and I'm going to talk about blood vessels. They are the coronaries, great arteries, and the coronary veins, and basics about the valves and the chambers of the heart and the septum. Heart is located in the chest cavity, where the chest cavity is guarded, surrounded by the ribs all around, and the sternum in the front and the spine in the back. Heart lies in the mediastinum cavity, where the mediastinal cavity is divided into two parts, superior mediastinum and the inferior mediastinum. The inferior mediastinum is divided into three parts: anterior compartment, middle compartment, and the posterior compartment. And the superior mediastinum contains the thymus with the thymic fat and the great arteries with the arch and the neck vessels. The inferior mediastinum, anterior compartment, contains the excessive thymic fat and the pericardial fat. And the middle mediastinum contains the heart with the root of the great arteries and the veins. And the posterior mediastinum contains the descending thoracic aorta. Heart has four borders. As we see here, it contains the right border, inferior border, left border, and the superior border. The right border is majorly formed by the right atrium and is part of SVC and the IVC. The inferior border it is formed by the right ventricle and a part of the left ventricle, which rests on the diaphragm. And the left heart border is formed by the left ventricle, the major part, and a part of a left atrium, which most commonly the appendage of the left atrium. And the superior border is formed by the right and the left atrium, the roof of the atrium, and the great arteries. And the heart has majorly three surfaces. The anterior or the sternocostal surface, predominantly made of RV. The inferior surface is also known as diaphragmatic surface, which is predominantly made of the LV and a part of RV, which rests on the diaphragm. And the right and the left surfaces, also known as pulmonary surfaces, which are surrounded by the hilum of both the lungs. This is a chest X-ray showing the location of the heart. You can see in this, the heart is located in the mediastinal surface, which is surrounded by both the lungs on either side. Also, you can see the trachea superiorly and right heart border, which is formed by the right atrium, which is joined by the SVC superiorly and the IVC inferiorly. The left heart border is formed by the left ventricle, and above it is a small appendage of the left atrium, and there is a pulmonary artery bay, which is just below the aortic knob, where superiorly the aortic knob, also known as aortic knuckle. The right heart border of the heart forms an angle with the right hemidiaphragm, known as right cardiophrenic angle, and the left heart border of the heart forms an angle with the left hemidiaphragm, known as left cardiophrenic angle. This is the same chest X-ray, but with a color representation. So you can see here we have shown the venous side in the blue and the red the left side. So the main intention of showing this diagram is to show you the location of the innominate vein, which most commonly you can encounter in the suprasternal arch, which is very important while doing the sternotomy, because it can be inadvertently injured during dissection. You can see the innominate vein draining into SVC. The SVC drain into the right atrium. It will further drain into the right atrium, then into the pulmonary arteries. This is all shown in the blue. And next, the pulmonary veins, which are shown in the red, they drain into the left atrium, that eventually drain to the left ventricle, then it will be drained to the finally to the aorta. From the ascending aorta, the first the branch comes from the neck, which are the arch vessels which drain into the upper limbs and the head and neck. So once we open the sternum, so next we see is the thymic fat and the prepericardial fat. Once you open the pericardium, next what we see is majorly the anterior surface, which is formed by the right ventricle. So here I have shown the diagram. Basically, I just want to show the anterior surface of the heart, what all you can see once you open the pericardium. So as you can see, we can see the right ventricle, right atrium, SVC and the IVC draining into the RA. Then comes the aorta next to the SVC and the pulmonary artery to the left of the aorta. Then you can see the left ventricle on the left side and the arch vessels which are supplying the both upper limb and the head and neck. This is a diagrammatic representation of the coronary supply of the heart. So once we open the pericardium, so you can see the coronary arteries. So heart is supplied by the two major coronary arteries, that is the right coronary artery and the left coronary arteries. The right coronary artery, which arises from the root of the aorta from the right coronary sinus, and the left coronary artery, which arises from the left coronary sinus from the root of the aorta. Here you can see the right coronary artery, which runs anteriorly and then downwards in between the right atrium and the right ventricle. And you can see the left coronary artery. First it origins as left main coronary artery, which originates from the left side of the left sinus of the aorta, and it passes around posterior to the pulmonary artery. Then it comes around the pulmonary artery, then divides into left anterior descending and the left circumflex artery. And the right artery, as you can see, it will give multiple branches before terminating as a posterior descending artery. The left main artery divides into LAD and circumflex. The LAD then divides into multiple branches, which I am going to show you in the next slides. And the circumflex artery also gives further branches. So now coming to the basic anatomy of the right coronary artery. Actually, as I mentioned before, it originates from the right coronary cusp of the aorta. It travels in the right atrioventricular groove, then terminates in the posterior interventricular groove, and then it divides into, actually the coronary artery, right coronary artery is divided into proximal, mid and distal RCA. So the division is based on the location of the artery. As you can see in the diagram, the proximal RCA is up to the origin of the right ventricular branch, and the mid RCA from the right ventricular branch till the acute marginal artery, and the RCA after the acute marginal artery is known as distal RCA. Now coming to the branch of the arteries, the right coronary artery, the first branch will be the sinus nodal artery, the SA nodal artery, and it also gives rise to one conus branch, that is the right conus. Then it gives a branch to the right ventricle. It can give either one or multiple right ventricular branches. Then the next branch will be the acute marginal artery, which most commonly it forms near the inferior margin of the heart. Then the artery finally divides into posterior descending artery and the posterolateral basal artery. I have mentioned here one AV nodal artery. So 90% of the cases, the RCA gives AV nodal artery, which supplies the atrioventricular node, and the posterior descending artery, it is originating from the right side in 90% of cases, where it is known as right dominant system. In 10% of the cases, it originates from the left side, and where it is known as left dominant system. The dominancy of the coronary is based upon the origin of the posterior descending artery and the posterolateral basal arteries. This is the diagram showing the anatomy of the left coronary artery, where, as I mentioned before, The left coronary artery originates from the left coronary cusp, which travels posterior to the pulmonary artery. It comes around the pulmonary artery, dividing into left anterior descending and a circumflex artery. The left anterior descending artery, it gives rise to multiple branches. So laterally left with diagonal branches, it can vary from 1 to 4. The numbers are not constant, and then it gives rise to multiple septal branches, which are the small branches which arise perpendicular to the LAD, which runs posteriorly and supplies the septum, mostly 2/3 of the septum. The LAD is also divided into 3 parts, which I'll talk about in the next slide. So here you can see the left circumflex artery, which gives rise to multiple branches, the marginal branches also known as obtuse marginal arteries. Most of the time, the circumflex artery continues and terminates as the OMs, or in 10% of the cases, it can give rise to posterior descending artery, where it is known as left dominant system. In 20% of the cases, it will give rise to posterolateral basal artery, where it is known as codominant system, and 10% of the cases, PDA, known as completely left dominant system. Now coming to the coronary venous system, the blood is drained from the heart, which from the coronary veins, which accompany the coronary arteries. As you can see, mentioned the great cardiac vein, which accompanies the left anterior descending artery, the middle cardiac vein, which accompanies the posterior descending artery, the small cardiac vein, which accompanies the marginal branches and the artery branches, the posterior vein of the left ventricle, which accompany the marginal branches of the left ventricle, and they finally drain into the coronary sinus. This sinus opens into the right atrium. So once you open the heart, all we see as the 4 chambers of the heart. The chambers of the heart on the exterior surface are demarcated by the sulcus and the grooves. The groove between both the atrium is known as interatrial groove, also known as Waterston or the Sondergaard's groove. Both the atrium and the ventricle are divided by the atrioventricular groove, and both the ventricles, right and the left ventricles, are demarcated by the interventricular groove from the outside. So interatrial groove is also known as Waterston's groove or the Sondergaard's groove, and also you can see we are shown in the diagram. So where the interatrial sulcus and atrioventricular sulcus they join posteriorly is also known as crux of the heart. We have shown here the interatrial groove, which runs just anterior to the pulmonary veins, up to the posterior to the inferior vena cava. This is another picture showing the coronaries running in the groove. You can see here the right coronary artery, which originating from the right cusp, which runs into the right atrioventricular groove, going posteriorly. Then you can see the next diagram where the right coronary artery coming posteriorly, giving rise to the right marginal artery, then giving rise to posterior descending artery. Also, you can see in the second diagram, posteriorly the circumflex artery giving rise to the left marginals and the posterior descending artery in dominant systems. So that is the coronaries. Now I'm going to talk about the valves of the heart. The heart has 4 valves, which are embedded in the fibroskeleton of the heart, which guard the chambers of the heart. The valves are made for unidirectional flow across valves. As shown in the diagrams, the 4 valves, the tricuspid and the pulmonary valve, which are the right side valves on the right of the heart, and the mitral valve and the aortic valve on the left heart. Here you can also see the coronaries, which are originating from the root of the aorta, the right coronary artery, running into the right atrioventricular groove, and the left coronary artery, after originating, runs posterior to the pulmonary artery. Then after once it comes out, divides into left anterior descending and the circumflex artery. We can also see the commonly aortic valve is tricuspid, the pulmonary valve is tricuspid, and the mitral valve is bicuspid, and the tricuspid valve, as you say, is the tricuspid. The aortic valve, it can be bicuspid normally also in 2% of the populations. Coming to surgical anatomy of the heart, for the valves. In valves, so when we talk about valve surgery, it has to be on-pump cardiac surgery. So surgically, what is important for us is a cannulation and how do you give the cardioplegia. So coming to the strategy of cannulation, so most probably the arterial cannulation, most of the time we use the ascending aorta, and cardioplegia, it can be either antegrade or retrograde. The antegrade cardioplegia we most commonly give in the aortic root, or in some aortic cases where we have aortic regurgitation, we can give through coronary artery also once you open the aorta. And retrograde plegia, where the cannula is passed through the coronary sinus through the RA, then the plegia is given. Then the venous cannulation, it can be either single cannula through the RA or the bicaval using the SVC and IVC. So the venous cannulation can differ because when we are planning to open the right atrium, so we have to cannulate the SVC and IVC. When doing aortic surgeries like aortic valve surgeries and ascending aorta, we can use right atrial cannulation, single cannulation. So coming to the each valves, so anatomy, surface anatomy, I'm going to discuss about the incisions and for the demarcations. So coming to the tricuspid valve surgeries, so in tricuspid valve, we most commonly use the ascending aortic arterial cannulation and root plegia into the ascending aorta, and bicaval cannulation, as I mentioned, because we are going to open the right atrium here. So the line of incision will be, as I shown in the first diagram, the incision will start from the appendage of the right atrium, running just posterior to the inferior vena cava. So as you can see, the line is parallel to the atrioventricular groove here, and you can also see the venous cannulations here. So this is a diagram. Once we give the incision onto the right atrium, and once we reflect the right atrium, this is the wave we see. So you can see the retracted wave. The anterior wall of the right atrium is retracted. Superiorly, you can see the tricuspid valve. You can see the three curves of the valve. Just below it, we have just shown the position of the atrioventricular node. Below that comes the coronary sinus. And after that, you can see inferiorly the fossa ovalis, and the left side is the superior vena cava, the right side is the inferior vena cava. So this is the axis for the tricuspid valve surgery and even the atrial septal surgeries. So that is the tricuspid. Now coming to the mitral valve. Mitral valve surgery, as we know, we can either access the mitral valve either to the left atrium or to the right atrium. So most of the times when the left atrium is huge or it is big, it is visible in the pericardium, we can directly access the mitral valve by incision into the left atrium. Or sometimes when the left atrium is very small, then we may have to go through the right atrium transeptal approach. You can also see sometimes even the left atrium is very small and the right atrium is also small, then we can use biatrial approach dividing the septum. We have to open both the right atrium, left atrium, and we divide the septum also. So here the diagram is showing, so as you can see, we have done the cannulation, bicaval cannulation, because we are going to retract the right atrium, which can hamper the drain of the blood. So we have used bicaval cannulation. So I have shown here the line of incision. I can see that it will be incision will be little anterior to the pulmonary veins. Yeah, you can see the right superior pulmonary vein here. So the line of incision will be posterior to the shoulder grafts or the interatrial groove. So in the diagram, second diagram, you can see the incision is made. It will be just posterior and parallel to the interatrial groove. So this is the other diagram showing the line of incision. So you can see in the this is the second incision, as I told, where if the left atrium is small or it's not accessible, then you can access you can enter the left atrium through the after incision into the right atrium. You can see here the incision on the right atrium will be parallel to the atrioventricular groove. So once we incise the right atrium, so second diagram shows the reflected surfaces. That is once we reflect the walls of the right atrium, you can see the clearly the septum of the the interatrial septum. We have in the dotted lines we have shown the line of incision in the interatrial septum, which will be open and will access the mitral valve. Now coming to the aortic valve and the ascending aorta. So this is a diagram showing the representation of the root of the aorta, ascending aorta, and the arch of the aorta. So as you can see, the root of the aorta, which is made of three components, that is sinus of Valsalva, sinotubular junction, and the atrioventricular valve. The annulus. So aortic annulus is the lowermost part of the attachment of the leaflets of the aortic valves. Then coming to the dilated part is known as the sinus, which where the origin of the coronaries also takes place, and which go continue as a ascending aorta. Then the arch of the aorta, where you can see the brachiocephalic artery is the first branch of the arch of the aorta. Then comes the arch, then gives the left common carotid artery and the left subclavian artery. Here, you can also see pulmonary artery is shown very close to the ascending, the arch and the descending aorta, and there is a small connection which is the PDA. On the other diagram, which is also a color diagram showing the root of the aorta, here we have shown the cusp of the aortic valves. You can see the three cusps are there, giving the Mercedes-Benz sign. They are the aortic leaflets. Then on the base is the aortic annulus. You can here in the second diagram you can see the junction of the LUOT and the aorta, so which is the narrowest part. Then comes the sinotubular junction, ascending aorta. Then the aorta is divided into ascending aorta, arch of the aorta, and the descending aorta. So coming to the surgical part of the aorta, so most of the surgeries in the aorta are aortic valve surgeries, and the ascending aorta in case of dissections and the aneurysms. Then comes surgery of the arch of the aorta and the descending thoracic aorta. Here I am going to talk about only the ascending aorta and the root of aorta. As I mentioned, aortic root is formed by aortic annulus, sinus of Valsalva, and the sinotubular junction. You can see the first diagram, which shows the junction of the left ventricle and the aorta, and also the base of the aorta as the aortic annulus. And the third line is the sinus of Valsalva, and the fourth line is the sinotubular junction. The second diagram showing, you can see the base of the leaflet, where the lowest point of the leaflet, the attachment, is known as the aortic annulus, where the measurement of the aortic valve is taken for deciding the size of the valve. Wow. Then comes the atrioventricular junction, ventricular aortic junction, and the sinus of Valsalva, and the sinotubular junction. Okay, this is a slide showing the cannulation during the aortic and ascending aortic surgery. So most commonly during other valve surgeries like mitral and the tricuspid valves, or any other surgeries like septal surgeries, atrial septal surgeries, we can cannulate in the ascending aorta, where we should have adequate space for cross clamping and cardiac lesion line. But when it comes to the aortic valve surgery and ascending aorta, we need more space in the aorta for the surgeries. So we have to do the arterial cannulation little higher up. So most commonly we can do high arterial cannulation at the base of the innominate arteries. Here, that care should be taken to avoid the selective cannulation of the neck vessels. Then proper direction of the flow of the canal also should be maintained, just to avoid, as I told, selective perfusion of the neck vessels and the arch. This is a diagram showing, as you can see, the aortic annulus. Here we have shown the coronaries also, the right coronary artery, left coronary artery origin from the sinuses and the sinotubular junction. Thank you.